Hydrocele Jared M. Patton, M.D., M.S. John E. Laird, M.D., FOFP. FOMA Basics Description: a collection of fluid between the parietal and visceral layers of the tunica vaginalis within the scrotum communicating hydrocele. Patent processus vaginalis. Direct communication with the peritoneal cavity contains peritoneal fluid almost always with associated indirect inguinal hernia. Decreases in size with recumbent position. Non-communicating hydrocele. The processus vaginalis is not patent. No direct connection to the peritoneal cavity. Fluid contained is from the mesothelial lining. Can be isolated to the cord with the distal and proximal portions of the processus vaginalis closed. Acute hydrocele. Fluid collection resulting from an acute process within the tunica vaginalis, typically involving only the scrotum system, affected. Urogenital pediatric considerations in a communicating hydrocele. Consider contralateral inguinal exploration to rule out an occult indirect hernia. Epidemiology: predominant age. Childhood incidence estimated at 0.74.7% of male infants. Prevalence 1,000/100,000. Estimated at 1% of adult men. Etiology and pathophysiology: incomplete closure of the processus vaginalis trapping peritoneal fluid anywhere along the length of the tunica vaginalis. Failure of closure of the processus vaginalis maintaining a communication to the peritoneal cavity. Imbalance of the secretion and reabsorption of fluid from the lining of the tunica vaginalis. Infection. Tumors. Trauma. Ipsilateral renal transplantation. Risk factors: ventriculoperitoneal shunt, exstrophy of the bladder, cloacal exstrophy, Ehlers-Danlos syndrome, peritoneal dialysis. Commonly associated conditions: testicular tumors, scrotal trauma, ventriculoperitoneal shunt, nephrotic syndrome, renal failure with peritoneal dialysis. Diagnosis: history: acute, subacute, or chronic swelling of the scrotum or inguinal canal. Frequent changes in size of the hydrocele with position change or activity, indicative of communicating, usually painless and less acute. Onset: sensation of heaviness or pressure in the scrotum, pain radiating to the flank/back. Physical exam: swelling in the scrotum or inguinal canal. Scrotal mass, usually fluctuation in size with change of position. Communicating hydrocele. Scrotal mass that transilluminates. Differential diagnosis: indirect inguinal hernia, orchitis, epididymitis, varicocele. Traumatic testicular injury, testicular torsion or torsion of appendix testes, testicular neoplasm. Diagnostic tests and interpretation. Initial tests: lab, imaging, inguinoscrotal ultrasound. US can demonstrate the presence of bowel, e.g., distinguish incarcerated hernia from a hydrocele of the cord, as well as the presence of testicular torsion. Testicular MRI when US is unable to distinguish. Etiology: Doppler US or testicular nuclear scan can distinguish testicular torsion. Alert: aspiration of a hydrocele for diagnosis is not indicated and may lead to severe complications if herniated bowel is present. Test interpretation: patent processus vaginalis on imaging in communicating hydrocele. Treatment issues for referral: urology, referral for symptomatic adults or if underlying diagnosis is unclear. Pediatric urology/surgery, referral for children with symptomatic non-communicating hydrocele. Children with communicating hydroceles can be expectantly managed until at least 2 years of age to allow time for spontaneous resolution, unless there is a concern for inguinal hernia. 1. C. New onset hydrocele in late childhood and pre-adolescent patients typically resembles the adult type hydrocele pathology. 2. B. Surgery/other procedures. Children. Surgical treatment is generally deferred until 2 years of age because many hydroceles will spontaneously resolve. Some evidence shows that delaying longer than 2 years may be appropriate and decreases unnecessary surgery. 1. C. When surgery is indicated, children with communicating hydroceles may undergo either open or laparoscopic approach. Open inguinal approach involves ligation of the processus vaginalis and excision, distal splitting, or drainage of hydrocele sac. In a hydrocele of cord, the sac can be completely removed. Open scrotal approach involves ligation and removal of the processus vaginalis. The benefit of this approach is improved cosmesis and decreased operative time. 3. B. Laparoscopic repair offers the benefit of contralateral exploration. Adults, no therapy is needed unless the hydrocele causes discomfort or unless there is a significant underlying cause such as a tumor. Aspiration of the hydrocele with installation of a sclerosing agent has been successfully used in adults. 4a. If resection is indicated, a scrotal approach with resection of hydrocele sac has the lowest recurrence rate. Postoperative complications as well as cost and time to work resumption were less in treatment by aspiration and sclerotherapy versus resection, but the recurrence rate was higher. 5a. The recurrence rate and low patient satisfaction may relegate aspiration and sclerotherapy as an alternative option only when resources for surgery are limited. 6a. Admission, inpatient, and nursing considerations. Open inguinal or scrotal approach is typically performed as an outpatient. Laparoscopic approach in pediatric patients may require 24-hour admission for postoperative monitoring. Sclerotherapy is a same-day office procedure. Ongoing care follow-up recommendations. Patient monitoring depending on method of treatment. Initial follow-up is generally in the first 4 to 6 weeks. With sclerotherapy, follow-up is for confirmation of resolution or to proceed with retreatment. Postoperative follow-up at 2 to 4 weeks and subsequent 2 to 3 month intervals until resolution of any postoperative complications. Prognosis: low risk of long-term sequelae with either treatment method. Complications: complication rate for a scrotal approach may reach 30%. Postoperative traumatic hydrocele is common and usually resolves spontaneously. Injury to vas deferens or spermatic vessels. Suture, granuloma, hematoma, wound infection. Recurrence. Reference